All right, Chapter 4, Medical, Legal, and Ethical Issues. We're going to start with something that confuses a lot of people, but it's important to understand the difference of, and that's scope of practice versus standard of care. So scope and practice is going to be considered regulations and the ethical considerations that define what you can do. So these are the extent or limits of your job. In pretty simple terms, it's what you can and cannot do as an EMT. It's defined by your state licensure, certification, regional protocols, and online and offline medical control. Standard of care, by contrast, though, is the skill or judgment expected under similar circumstances by a similar trained provider. So would another EMT do it the way that you're doing it, and does that make it correct? So to compare the two in simple terms, scope of practice is what you can do, while standard of care is what you should do. Consent and refusals. So consent is going to be permission for something to happen or agreement to do something. Our types of consent for EMS are express consent, which is going to be given by adults who are of legal age and mentally competent to take and be able to give consent. And implied consent is presumed patients or parents or guardian would give if they could. An example of this would be if your patient was unconscious, we're going to assume that if they could tell us to help them, they would. Or if your patient is physically or mentally unable to make the decision, we would assume that they would want help if they could tell us. Some of our special circumstances when it comes to consent are going to be things like children and mentally incompetent adults. So a parent or guardian has to give consent, and if not, then the person standing in local parentheses may give consent. So that's going to be your teachers, your child care providers, your principals, someone who represents the school. In cases where life-threatening illness or injury, when no parent or guardian is present, then we go off of implied consent. If you are over 14, you may consent or refuse, but only if no parent is present. Emancipated minors may consent on their own with no parent present, and pregnant minors can consent for care in relation to their child or their pregnancy, but otherwise a parent can overrule them. When a patient must be transported against their will, we need to ensure that police are involved, and if physical restraints have to happen, we have to ensure that you have the ability to remove them. I.e., if the police officers have to physically put handcuffs on a patient, you cannot transport them without them being present with a key. You may not decide a patient needs to go without consent without consulting medical control and/or PD. So you're dispatched to a motor vehicle accident. You arrive on scene to find a confused patient in the driver's seat. What kind of consent are you using to be able to treat them? So this would be implied consent because the patient is confused and not able to make decisions. You're dispatched to a motor vehicle accident with an 18-year-old female who was driving and rear-ended another car. 16-year-old female. She does not want to be transported, but mom on scene states she has to go with her to the ED. Do you transport? Why or why not? What type of consent is this? So it's going to be express consent, and we are going to transport because she's 16 and mom's on scene. We dispatched to a local school for a 6-year-old with a fall and deformity to left arm. No parents present. Are you able to treat the child? If so, what kind of consent? So there are no parents present. So we're going to utilize the in local parentheses, and the teacher is going to be the one that can give consent, or the principal. We dispatched an overdose and found a 36-year-old male laying in bed with no family. Can you treat the patient? If so, what kind of consent is it? If he's not able to talk to you, then it's implied consent, and we can. Sometimes patients will not wish to be transported or treated in the manner you believe is best for them, and that's where patient refusal comes in. Patients can refuse treatment or transport, or just treatment. So if you have a patient who called for low blood sugar, after eating he feels better and doesn't want to go, he could refuse to be transported. If you have a patient that was involved in a motor vehicle accident, and your protocol states they should have a C-collar placed on them, and he refuses to have one, stating it's too uncomfortable or doesn't want to wear it, they can refuse to have it. However, there's some rules that go into that. So the patient must be legally able to consent. This means they have to be the right age or an emancipated minor. They have to be awake and oriented. Nothing that can impair their judgment can be on board. So we can't have drugs, alcohol, they can't be altered, and they have to be fully informed. So the patient in the previous slide that didn't want to have the C-collar would have to be informed of the risks, such as further injury to their neck, the possibility of paralyzation, etc., if they do not wear the C-collar. And then we make them sign a release form. Most of these are digital these days, but it's designed to release the crew and agency from liability. Patient refusals tend to be what calls us to court, so try to protect yourself. Spend some time talking to the patient, try to understand why they do or do not want to be transported, try to brainstorm solutions. So things like money, who's going to take care of their pets, who's going to take care of their family, etc. Try to find other ways or things that may work so that the patient can be transported. Then ensure you inform the patient of your consequences. Further injury, illness, up to and including death. Have both the patient and a witness who is not an EMS provider, if possible, sign it. So what happens if I really think they need to go and they really don't want to? So the first step is going to be call medical control. Let the doctor get involved and make the decisions. You can try to call a family member, maybe a mother or a daughter can convince them to go. If both of those fail, call law enforcement, and then document everything you did. Ultimately, if the patient's alert and oriented, we can't force them to go. And if you try to, it's called assault or battery. And so we're not able to do that. DNR. So a DNR is a do not resuscitate order. It's a legal document expressing the patient's wishes if the patient is unable to speak for themselves. They may be part of an advance directive or may be part of a physician's order for life-sustaining treatment or a POLST. In Virginia, they're this really pretty yellow color. However, copies of these are okay too. So they can be yellow or white. You may also have them as a order. This is specifically going to be if I'm going from a facility to a facility. So if you pick up a patient at a nursing home and you're taking them to like Danville ER, this order that states that the patient does not want to be resuscitated would count. And then these are approved DDNR bracelets or necklaces, which means that these track back to an on-file DNR and would count as a valid bracelet or DNR in order to not resuscitate a patient. So a couple of the other legal issues to address are going to be negligence. So negligence is defined as something was not done or was done incorrectly. In order for negligence to happen, there had to have been a legal duty to act, there was a breach of that duty to act, and the breach of that duty caused injury or harm. So what is a duty to act? A duty to act is a legal obligation to provide care. So in order for there to be a duty to act, the provider had to be on duty, they stopped to assist in an incident, they're traveling in an EMS unit where it would not otherwise hinder patient care to stop, and there was no unreasonable threat to provider safety. If the provider feels like they are not going to be safe to stop and take care of a patient, then there is not a duty to act. You can step out and wait for PD to secure the scene, and that's okay. A breach of duty is when you have failed to do what is in your scope of practice or your standard of care. There was a failure to act, so you didn't act as someone at the same level would have. For example, not giving oxygen to a patient with low O2 saturations. You acted inappropriately, so you did care that wasn't correct for the patient, as in we gave them the wrong medication or an expired medication. Or you abandoned them, so we stopped taking care of them without the patient consenting to us stopping. Once you take patient care, you can't leave until a provider of an equal or higher level accepts responsibility and report is given. This includes at the emergency room, report has to be given to an RN before you can leave. So the duty to act, the obligation to provide patient care to a patient. It's not always clear, especially if you're off duty or you're on duty in a different jurisdiction. So try to follow your own laws and your own consequences, or your own conscience. Good Samaritan law. So it grants immunity for liability if a rescuer acts in good faith within their level of training. What this is supposed to do is protect you. If you stop at a motor vehicle accident and you attempt to save somebody, maybe pull them out of a burning vehicle, and it actually broke their neck worse than it already was, this protects you from getting in trouble for it because what you did was try to help. It does not, however, protect you from negligence or any violation of law. Go ahead and apply your knowledge. You can pause it and read these. So in this situation, because there was not a DNR present and we don't have our hands on it, then we would have to provide CPR. Again, pause it and read it, and then restart when you're ready. Because you're off duty, you do not have a obligation to stop and render aid. However, once you stop, you are obligated to stay until someone else arrives. Again, pause it, read it, and then we'll talk about it. So even though you are in the hospital, you cannot leave the patient until you give a report to a nurse. So you need to go find someone. You need to be able to turn over to somebody so that your patient is being taken care of. And then one more. So you are responsible for this. This medication was 6 months out of date, and had you checked your truck appropriately and checked your rights prior to giving the medication, you would have known. And it's considered negligence. So here are some examples of some medical IDs. So bracelets, necklaces, anklets even at this point, and there's an app on your phone. All these are considered medical IDs. They're going to give you a history, things like diabetes, pacemaker, epilepsy. They might give you an example of allergies like bees or medications, or they can refer you to a QR code or a website to get you a little bit more information. Another thing to talk about is safe haven laws. So these vary from state to state, but in Virginia, it allows a parent to give up an infant who is 14 days old, unharmed at any hospital or rescue squad, without question. The parents may provide information if they wish to, but they do not have to. Any infant turned in under the safe haven law must be taken to the hospital for evaluation, and then there will be placement given to social services. So what this does is allow a parent who has a child under the age of 14 days could come to your rescue squad and give you the baby, and you cannot ask questions. You just take the child and transport them to the emergency room. Crime scene. So recognizing a crime scene. As soon as possible, recognize that you've entered a crime scene. Try to preserve the evidence. This comes secondary only to patient care, though. So cut around clothes and holes in clothing. Watch where you stand. Take note of where you place bags, supplies if possible. And then if you have to move something to take care of the patient, just make sure you document it. Things like, did you see anything on top of the patient, move the patient, etc. And then mandated reporter. So as an EMT, you're a mandated reporter of abuse and neglect. So what happens is if you see someone, an adult or child, that you think has been abused or neglected, you have to report it. This is children with obvious signs of abuse, elderly patient who's unable to care for themselves, mentally handicapped adult who doesn't have food or running water. And then we also have to report violent crimes such as gunshot wounds and stabbing. There's a reportable line to do this, and we'll talk about it in class, as well as a website. The final thing to talk about is HIPAA. So HIPAA stands for Health Insurance Portability and Accountability Act. Came out in 1996, and it specifies what is protected health information, and it applies to all healthcare providers, including us. So protected health information is anything that is identifiable. And that means anything that could tell us who the patient is and deals with their past, present, or future physical or mental health. It can be oral, written, photographic, or electronic, or digital. You have to respect the privacy of the patient. Keep the information just like you would your own. Don't share it with others who are not involved in care, except as permitted, and keep disclosures to a minimal amount necessary. So how can we do it? We do have to share personal medical history to treat a patient. Things like medications, things like that, have to be shared with other EMS providers, hospital staff, flight crews, etc. Personal medical or health insurance information can be given to file claims, to pay for bills and for insurance. And it can be used for quality assurance and training. This means we can go through and try to train off the information. However, at that point, we're going to use the minimal necessary rule, which means we're going to keep it to as little as we need to perform QA. Most of the time, that means we don't have to have the name. But we would know that it's, an 18-year-old female, a 20-year-old male, whatever it may be. So how do we protect it? Make sure we don't share information over the radio. On scene, try to discuss with only first responders. Limit discussion with family members or friends unless it's needed to treat the patient. Don't discuss anything with the media, and that should help minimize incidental disclosures. En route to the hospital, share only as needed on appropriate treatment, again, not over the radio, and use secure communication methods such as a phone if you're given a patient name. Make sure you give a verbal report and a written copy of your report to the hospital, and then you can get a face sheet. And then be careful after the call with any discussion done. QA, CISD, which we talked about in the stress chapter, are all permissible. However, again, the minimal necessary rule applies. So we can't give a lot of information to law enforcement. So a police officer who's on scene and is medically trained and is assisting with patient care, we can give them information as a healthcare provider, or if it is a mandated reporting case. Otherwise, it is not up to us. Something like a PCR for a vehicle crash, they have to go through appropriate channels, such as request it through our public information officer. For something like a mass casualty event, healthcare information can be given to like American Red Cross or other entities like that. And then to protect it, make sure you don't leave your PCRs unattended. They should be locked in a cabinet when they're done. In addition, any notes or anything like that should be secured or shredded when you're done. Don't post examples for QA or QM without making sure you're at PHI. Make sure you use good quality passwords. And then any fax machine that gets PHI should be in a secure location. And remember that your patients have a right to inspect and copy their medical records, but not through y'all. That has to go through the proper channels at the rescue squad. And that should go through whoever is your company privacy officer. Make sure you're aware of policies on confidentiality of patient information, security, access, and use, and what to do for an incidental disclosure. So this is going to be really important as you guys start to do your clinical time. Make sure that you do not discuss anything that you hear or see while you're on the ambulance.